All right. Thanks again for joining us, guys. Tonight we're going to have a lecture on knee ligamentous exam and treatment. That'll be given by Jeff Thompson, who's one of our PGY4s, who's going to be going into sports. We got on the call, we got Joe Ippolito on the Peloton. He's a PGY4. And then Joe Galloway is driving home and going to join us when he gets home. So as always, we'll go over a little review from our previous lecture. That was foot and ankle. Jeff, can you go ahead?
Yep.
So we talked a little bit about foot and ankle arthritis and treatment options. So this question, if you guys follow us on Instagram, this was a similar question that was posted yesterday. So what ligament is injured when there's some laxity with the anterior drawer test when the foot is in dorsiflexion? And so the ATFL is the anterior tibiofibular ligament. Anterior talofibular ligament. B is calcaneofibular ligament. C is anterior inferior tibiofibular ligament. And D is posterior inferior tibiofibular ligament. All right. You can go to the next slide. So it's B, the calcaneofibular ligament. And so the anterior drawer test tests for either the ATFL, the anterior talofibular ligament, or the calcaneofibular ligament. And depending on the position of the foot, you can test either of those. So the way to remember this is think of which way it's going to put those ligaments on stretch. So if you look in the picture, I guess is my mouse coming up? Probably not, right?
No, I got you. Right here.
So if you point out, that's the calcaneofibular ligament. And so if you think about it, if you put the foot in dorsiflexion, it's going to stretch that ligament out. So then when you test anterior and drawer, it's going to be testing that ligament. If you look at the ATFL, if you put that in plantar flexion, you're going to stretch that ligament, and then you test the anterior drawer, and it's going to test that ligament. So just think about where the ligaments are, and then what position the foot is going to put them on stretch, and that's going to be tested. So next question is about the gait cycle. So at what point does the transverse tarsal joint lock? And what position of the heel is, or what position is the heel in when this happens?
These are hard questions.
So this one we talked about a little last week in, so I'll just go over it when we get a couple more people to answer. Oh, Joe's picking up the intensity on the bike. Alrighty. You can go to the next slide. So it's in the toe-off phase. So the transverse tarsal ligaments joint, we're talking about the talus and the calcaneus. And so when your foot hits in heel strike and it's just on normal surfaces, it wants to be loose. And that allows you to be able to walk on uneven surfaces. When you toe off, and to get that gait cycle where you need to push off, you need to lock your foot. And that allows you to get that lever moment to push off. And so when that happens, your tarsal joints have to lock. So the foot goes in varus, and then that locks the joint. So if you look on the picture on the right, or on the picture on the left, they're kind of lined up. And when they're lined up, they can have motion through the joint. When the calcaneus goes into varus, it changes the alignment of those joints, so they're no longer lined up. So then they lock. And because when they lock, that makes the foot stiff, and that allows the foot to push off the grounding and have some a lever moment and allow you to push off and ambulate. And then question number 3. So we talked about ankle arthrodesis last week. And so is there any visual change in their gait when you have an ankle arthrodesis? All right. Next slide. So it's sometimes in about 2/3 of patients, their gait, it looks normal. So this was just a kind of a trick question. And you can go to the next one. So for our bonus question, if you had to choose one meal for the rest of your life,
It's not even a question.
what's your answer, Joe?
Burger.
Burger?
You got protein, you got carbs, everything you need in life.
Same thing as a sandwich.
I'm
Jeff,
in
relax.
tacos and pizza.
Is a burger a sandwich?
Ooh, no. Don't be ridiculous.
I don't know. We got a lot of tacos.
What?
A lot of tacos.
Wow.
Yeah, I don't know if I could do tacos the rest of my life.
You have different choices. You can do chicken. Yeah. Alrighty. And as always, if you guys have questions, just feel free to type it in the chat, and we'll answer it as we go.
Okay, so we can get started on our lecture tonight. Again, as Jeremy said, I'm Jeff, one of the PGY4s. I'll be applying for sports fellowships this coming fall, so it'd be good to give you guys a topic on evaluating ligamentous knee injuries. What we're going to go over today is kind of the basic anatomy of the major knee ligaments, talk about physical exam, including the injury-specific maneuvers, and then also go over a brief introduction to ACL treatment. So going right into the knee anatomy. We're looking at the anterior cruciate ligament, the ACL. This is something that you got to remember that it comes off the posterior medial aspect of the lateral femoral condyle, comes down to the anterior tibial eminence. The ACL itself is divided into 2 separate bundles. You have an anterior medial bundle and a posterior lateral bundle. Sorry for that typo. The anterior medial bundle is the one that's, again, as you can guess, it's more anterior. If you think about it, it's tight in flexion. As you bring the knee through flexion, the structure that's more anterior becomes tight as the posterior structure becomes lax. And then again, there's a posterior medial bundle that is vice versa. It's lax in flexion and tight in extension. The function of the anterior cruciate ligament is a primary restraint to anterior tibial translation. Again, that's what we'll be seeing on most of our ACL-specific examination maneuvers. The ACL is also a secondary restraint to varus, particularly when the knee is in extension and internal rotation. The blood supply of the ACL is provided by the middle geniculate artery and is innervated by the posterior articular nerve that is the branch of the tibial nerve. Conversely, we have the posterior cruciate ligament, which comes off the lateral aspect of the medial femoral condyle down to the posterior aspect of the tibia. You got to remember that insertion point is actually behind the tibia, below the articular surface, which becomes particularly important when you're trying to find the footprint in a PCL reconstruction. The posterior cruciate ligament has an anterior lateral and posterior medial bundle. And again, you can remember this by the ACL and PCL being opposite in terms of anterior lateral and anterior medial. And you can remember that the PCL is your PAL with a anterior lateral bundle. So for the PCL, the anterior lateral bundle is similarly tight in flexion and lax in extension. Conversely, where the posterior medial bundle is lax in flexion and tight in extension. The PCL itself is the primary restraint to posterior tibial translation, which is what you'll be testing with posterior drawer sign, as well as a secondary restraint to varus and valgus, as well as external rotation at the knee. Medial collateral ligament has two separate distinct portions. There's a superficial medial collateral, which is our primary restraint to a valgus force. It is originates on the medial epicondyle and continues down to the anterior medial face of the tibia. It travels deep to the pes tendons and has a broad insertion about 5 to 7 meters below the joint line. Separately, there is a deep medial collateral ligament that you can see here, much closer to the joint line, inserts onto the medial meniscus as well as the tibial plateau. It has more of a function to stabilize the meniscus rather than provide a restraint to valgus force. The lateral collateral ligament originates on the lateral epicondyle of the femur and travels down to the medial fibular head. This acts as a primary restraint to varus stress, and it's also a secondary restraint to external rotation. In addition to our 4 main ligaments about the knee, we also have to talk about the posterior lateral corner, which is actually a complex of 3 major static stabilizers about the knee. Again, we have the lateral collateral ligament, which in this diagram is also labeled as the fibular collateral ligament. Again, it's the same thing with 2 different names. We also have the popliteus tendon, which inserts anterior and distal to the LCL origin. That is a primary static restraint to external rotation of the tibia. Finally, there's also the popliteofibular ligament that connects at the musculotendinous junction of the popliteus tendon to the fibular head. In terms of helping remember where all of these structures are, particularly you may be asked the orientation of the LCL and the popliteus. You need to remember that the popliteus is the mnemonic ADD, where the popliteus is anterior, distal, and deep to the LCL tendon. Okay. Moving on to physical exam. When we're first seeing a patient, particularly one that we suspect has a ligamentous knee injury, we got to go through the same standard different physical examination sections as you always use when seeing a patient. Got to first inspect to see the skin, see if it's intact, see if there's any swelling, erythema, see if there's any obvious trauma to the knee or gross deformity. Next, you look for palpation. You'll try to find the point of maximal tenderness, note whether it's on the joint line or somewhere else within the knee, and additionally see if there's been a fusion. Next, you'll test the active and passive range of motion at the knee. Important to note that normal range of motion is actually from -10 degrees of extension, which means that the knee is in recurvatum, or it is actually extended past 0 degrees of extension, all the way to 130 degrees of flexion. Additionally, you'll note that the rotation of the tibia in relation to the femur varies as you go through flexion. If you straighten your leg out and note in full extension, there is no rotation present at the tibia. As you go through the flexion arc, you'll note that once you get to 90 degrees of flexion, there is a range of rotation of the tibia between 45 degrees of external rotation and 30 degrees of internal rotation, meaning that you're able to have a rotation in play at the knee joint during flexion. Finally, want to use the neurovascular exam. Again, you'll pay attention to the major dermatomes about the knee, about the lower leg. The obturator nerve supplies to the medial thigh. The femoral nerve covers the anterior thigh. Posterior or sciatic nerve covers the posterior lateral calf. Again, the foot is divided dorsally by the common perineal nerve and plantarly by the tibial nerve. In terms of motor function about the leg, again, the same nerves are tested, where thigh adduction, again, bringing the thigh closer to the midline, is supplied by the obturator nerve. Knee extension is supplied by the femoral nerve. Knee flexion is controlled by the sciatic nerve. Toe extension is by the perineal nerve, and toe flexion is by the tibial nerve. Finally, you'll check the vascular exam, look at pulses, the popliteal pulse that you find behind the knee, as well as dorsalis pedis on the dorsum of the foot, and posterior tibial on the medial aspect of the leg. You also will test a ankle brachial index. This is where you check the blood pressure down at the ankle, either at the posterior tibial or dorsalis pedis artery, and compare it to the brachium of an uninjured arm. So essentially, you're trying to figure out the percentage or the rate at which the blood flow or the pressure of the injured extremity compares to a normal extremity. If it's uncommon to have them to be exactly the same, but normal is considered anything over 0.9. If it's less than 0.9, that implies that there's some type of resistance, likely from a arterial injury, that is causing a decrease in blood pressure distally in the extremity, and that requires further investigation. This is particularly important in ligamentous knee injuries because these are common, particularly multi-ligamentous knee injuries. It's common to have a vascular injury that is associated with the knee dislocation. So when we're talking about anterior cruciate ligament injuries, these are typically non-contact injuries with an awkward landing. Again, our anterior cruciate ligament originates from the lateral femoral condyle down to the footprint on the anterior tibia, anterior aspect of the tibial plateau. Generally, these patients report a awkward landing and an audible pop. There's a immediate swelling and a large hemarthrosis. If there's not a large effusion, it's unlikely that there's an ACL tear because of the intra-articular nature of the injury. Additionally, you also note that patients will describe a quadricep avoidance gait. What this means is that while they're walking, they'll avoid putting the leg into full extension. This is because the ACL, which normally resists anterior translation of the tibia in relation to the femur, is no longer intact. And as the quadricep fires, it actually pulls and subluxes the tibia anteriorly. That causes instability and pain in the knee. The first test that we'll talk about for the anterior cruciate ligament is the Lachman's test. This is what's considered the most sensitive of all the different tests that we can do. You can do it on patients that are awake or asleep, as well as it has a grading scale where it either has grade 1, 2, or 3, which is described as the translation of the tibia in relation to the femur, as well as whether or not you feel a firm endpoint. An A would be essentially feeling the ligament itself snap taut as you're reaching the full excursion of the ACL. And a soft endpoint would be described as the soft tissue around the knee acting to decrease the anterior translation. You can really think about this if you're pulling a string or a rope taut. As you pull, your hands separate on the string. As you finally reach the full tension of the string, you'll note that there's a actual snap, and it can even be audible as well as palpable. That's what you're looking to feel on the Lachman's test. Again, it's something that you're going to have to unfortunately get get your hands on to figure out how it works best for you. But the general principles is that you will put the leg in 20 to 30 degrees of flexion. You use one hand to stabilize proximally on the femur, while your other hand attempts to translate the tibia anteriorly to test to see whether there's that firm endpoint. Additionally, how much the leg is actually, tibia is translating in relation to the femur.
Hey, Jeff.
Yeah.
Just to go back to that one, what do you think is more beneficial or important, the endpoint or the amount of translation?
I think the endpoint is the biggest thing that you can get. The amount of translation is very, I would say, or has a very low inter-observable reliability. Yeah. Judging what 5 millimeters of translation is, you're not going to be arguing with someone whether it's a 1 or a 2. Whereas if you say there's a firm endpoint or there's a soft endpoint, that's something that really can be discussed and has a much greater consensus.
Yeah, I feel the same way. Go ahead.
Additionally, when you're thinking about these tests, the probably main next step following all of these tests is not whether you're going to schedule an ACL reconstruction. It's whether you're using this as a screening tool to pursue some advanced imaging, which will then give you more information regarding the competency of the ligament.
Yeah, and I think you said it already, but I always go back to examining the normal side first, like you said in the physical exam, and do a Lockman there, because everyone's a little different. And so for me, it's always hard to kind of guess the amount of translation to assess that, but the end point and then comparing to the contralateral is kind of my go-to.
And that goes along with Vivek's question in the chat, asking if translation differs from person to person. Definitely does. Everyone has different excursion of the tibia, essentially depending on how the positioning and just competency of the ACL, particularly for this test. That's where examining a non-injured side is extremely important to figure out what their normal is, and then using that to compare. Second test for the ACL is the pivot shift test. This is really difficult to elicit on a patient who's awake. It does generally cause some pain, and typically the patient's guarding if it's an acute injury, so that you're not able to really elicit the shift that you'll feel. The way you perform this test is that you can take the leg from full extension to flexion. You'll put a valgus stress and an axial load on the knee. What this is doing is actually mimicking the injury pattern, where as the knee is in full extension and begins to flex, the tibia is translated anteriorly on the femur. As you reach about 20 to 30 degrees, the vector of the IT bands, particularly if you think about where Gerdy's tubercle is laterally, continuing up laterally up the thigh, starts to act as a posterior translation or posterior force on the tibia and reduces the tibia underneath the femur. So you'll note that there's a palpable shift and that there's a reduction as the tibia comes from its sublux to reduced position. Moving on to posterior cruciate ligament injuries. This is commonly described as a dashboard injury. It also occurs in patients that have a fall with a plantar flexed foot and can result from a hyperextension injury. Patients will describe most commonly some posterior knee pain associated with the injury. A couple different tests for the PCL injury is that you can note that there's something called a posterior sag sign. As you're comparing the knees in a supine patient, you'll note that there's a posterior shift of the tibia evident compared to the uninjured knee. If you think about looking at this graph, which is actually for our next test, the posterior drawer, if you have the knee flexed up compared to the uninjured knee, gravity itself will cause a posterior translation of the tibia in relation to the femur compared to an uninjured knee where the PCL is competent. Additionally, you can further exacerbate or put more stress on the PCL by doing a posterior drawer test. This is where you put the knee in 90-degree flexion. You directed a posterior force on the tibia, and note to see if there is a shift in the tibia in relation to the femur. We didn't talk about it earlier, but this is also something where you can do an anterior drawer test for an ACL to identify a ACL tear. But it's important to remember that if you have someone who has a posterior cruciate ligament injury, where the tibia is shifted directly posterior, you may actually feel anterior translation as you're completing the anterior drawer sign. But if you feel a firm endpoint, which gets back to Joe Ippolito's question earlier, you know that the ACL is intact. You got to be careful that you're not getting tricked by a initially sublux posterior tibia in relation to the femur, that anterior translation is actually just from the knee reducing itself rather than pathologic anterior translation of the tibia. Additionally, you can do what's called a quadriceps active test. This is where the patient has their leg extended, and you'll note that there's a posterior sag sign. So the tibia is translated posteriorly compared to the femur. As the quadricep is flexed, it's contracted and activated, tension through the extensor mechanism will translate the tibia forward, and again, reducing the tibia underneath the femur. So you'll note that that's essentially the reduction of the posterior drawer test that you're completing. The medial collateral ligament, again, is located on the medial side of the knee. This is due to a valgus injury, most commonly described in sports as a blow to the outside of the knee. So a force directed from laterally to medially will put the knee into valgus, and will put tension across the MCL, causing it to fail. Patients will typically describe medial pain about the knee. When testing the MCL, you look for valgus instability, both at 0 degrees and 30 degrees. You can note that if there's only valgus instability at 30 degrees, it can be described as a isolated MCL. If there is instability at both 0 degrees and 30 degrees, that means it's most likely a multiligamentous knee, with the MCL being involved, as well as either the ACL or the PCL. Essentially, one of your secondary stabilizers is then disrupted. This can also be graded as grades 1 less than 5, grade 2 5 to 10 millimeter of opening, and grade 3 more than 10 millimeters of opening. Lateral collateral ligament injuries, again, these are rare if it's simply involving the LCL itself, but conversely to the MCL, this is a varus injury pattern. Patients will describe lateral knee pain. The way to test for a isolated LCL injury is similar to the MCL. You'll note lateral opening, particularly if you obtain stress radiographs, as you can see here. A regular image, the knee appears to have normal alignment without any stress placed. However, once there's a varus stress placed on the knee, you'll see opening or widening at the lateral condyle. Conversely, you can do an examination under anesthesia and using fluoroscopy for a MCL injury as well, where you'll put a valgus load on the knee and observe for opening over the medial aspect of the knee. Similarly, you examine the knee at 0 degrees and 30 degrees. At 30 degrees is note that there's an isolated LCL tear, whereas if it's at 0 degrees and 30 degrees, you're likely to have a combined LCL and either ACL or PCL tear. Finally, we have the posterior lateral corner injuries. These are typically patients who describe lateral and posterior pain. Usually it's combined with other ligamentous injuries, so you'll be doing all the examination maneuvers we talked about before. But then there's also the particular dial test that you'll hear about for posterior lateral corner injuries. Again, you'll test for varus instability. Again, noting that at 30 degrees only, it's an isolated LCL. whereas at 0 and 30 degrees, you can have a combined LCL and ACL or PCL. Additionally, there's what's called the dial test, where you have the patient either lay prone or supine, and you compare the amount of external rotation with the knees both flexed to 90 degrees and flexed to 30 degrees. What you're looking for is combined as the comparative asymmetry of the amount of external rotation available at both lower extremities, both an injured and non-injured extremity, and it's considered significant or a positive test if it's more than 10 degrees of asymmetry. If it's, again, just at the 30 degrees of knee flexion, it's isolated posterior lateral corner injury. If it's asymmetric at 10 degrees of external rotation, 30 degrees and 90 degrees, it's both a posterior lateral corner and likely PCL injury. Okay. And finally, we have ACL injury treatment options. ACL is something that it is one of the more elective procedures that we have in orthopedics. For certain patients that have ACL tears, many patients do fine with physical therapy and lifestyle modifications. Typically, if you're not still competing in athletics or using your extremities for anything more than kind of running a straight line, usually you're fine without having your ACL fixed. If you are someone who does fit the category where you want to go undergo ACL reconstruction, generally the big categories to think about are autograft versus allograft. Additionally, you want to make sure that you fix any pathology that's also associated within the leg, within the knee, whether it's an MCL injury, meniscal tear, chondral injuries, or PCL and posterior lateral corner injuries as well. These are particularly important if you think about the meniscal tears or another ligamentous tear, in that these all act as secondary stabilizers for a particular different movement. So if you're fixing just the ACL without fixing, say, the meniscus as a secondary stabilizer, you're unlikely to have a successful outcome, or may still have some recurrent instability by just fixing part of the initial problem. So it's important to make sure you address everything as needed, and sometimes you need to do them in separate surgeries as well. When we're talking about allograft versus autograft, the first and the oldest option for ACL reconstruction is the bone patellar bone autograft. You see that there's bone present on both sides of the allograft. This helps in that it gives us rigid fixation and actually heals the quickest in terms of the graft incorporating into the femur and the tibia. One issue with the BTB autograft is it does cause anterior knee pain, and also can both put the patient at risk for both for a patella fracture, both during the surgery as well as during initial stages of rehab, because you are taking off a approximately 10 millimeter portion of the patella. Generally, this has about the same strength as the native ACL, where in terms of force, the native ACL can withstand up to about 2,200 newtons of force, where bone patellar bone autograft is about 2,600. Next graft is the quadrupled hamstring autograft. This is a autograft that's taken from the medial side of the knee. Again, you'll identify the pes tendons and use the tendon stripper to harvest the soft tissue. Generally, this is described as having a smaller incision, and also is known to have the highest load to failure. Again, with the normal ACL being about 2,000, this is actually double that strength with a maximum load to failure about 4,000 newtons. The issue with the hamstring autograft, in addition to having some issues with the harvest in terms of disrupting some branches of the saphenous nerve, causing some paresthesias along the medial knee, is that it also is what's called a suspensory fixation, whereas the bone patellar bone autograft is put into the knee and it's fixed directly at the joint line with either metal or plastic or PEEK screws. The hamstring itself has to be suspended between implants at the far cortices of both of the bones. So at the femur, you need to have the ACL graft go through the lateral femoral condyle, be suspended by sutures out to a cortical button on the lateral side of the femur. Additionally, on the other side, you have typically have suspensory fixation to the anterior medial aspect of the tibia, which then can put the graft under what's called a windshield wiper stress, where it's actually moving around within the boundaries of the cortices and not from the actual joint, which causes additional graft wear and some bone wear at the insertion sites. One of our last autograft options is the quadricep tendon autograft. This is essentially somewhat similar to the BTB autograft. It can be harvested through a small incision. One of the advantages of the quadricep tendon over the bone patellar bone is that you're not taking a piece of bone from, you don't have to take a piece of bone from the patella, reducing your risk of fracture. Additionally, if you are taking a piece of bone or thinking about the surgery itself, it's not over the anterior knee where pressure is put on by kneeling. So one of the common complaints of the BTB autograft is that it's residual anterior knee pain, and the quadricep tendon can potentially avoid that option. Whether or not you take bone from the patella can help limit the some of the downfalls of the quadricep tendon, in that if you are taking just a soft tissue graft, you have the similar issues that you do for a hamstring autograft, and that you have the suspensory fixation with the windshield wiper phenomenon. But again, that can be addressed by taking a small bone plug along with your graft. Moving on to allograft, there are a couple different treatment options that are typically used. Some surgeons prefer to use the Achilles tendon as an allograft. This is helpful in that it provides a bone plug off the posterior calcaneus, as well as having a long graft available in terms of matching whatever function you need or whatever distance you need for your graft. Additionally, you can use a hamstring tendon that is prepared the same way that a autograft would be. It again is fixed using suspensory fixation, but it does avoid the risks and the pitfalls that are associated with the actual graft harvest itself. And finally, you can also use a patellar tendon and a patellar bone allograft. This does provide the same advantage of having bone ingrowth at your graft site, but it also at the same time does have issues in that not all patients have the same distance between the patella and the tibial tubercle, such that there can be some graft patient miss patellar tendon itself. So generally, if you want to think about big picture or large groups, generally we use autografts in younger, more athletic patients undergoing ACL treatment options, whereas we'll use allograft for patients who are older. Generally, the choice of the autograft is determined by the surgeon as well as the patient in terms of what they feel is the surgeon is most comfortable with, as well as particularly for the patient if it's someone who may have more symptomatic anterior knee pain compared to having the issues from the hamstring or quadriceps autograft.
Hey, Jeff.
Yeah.
We're getting some great questions in the chat here. I just want to run a couple things by you, see what your thoughts are.
Oh.
One of the questions that was coming up from Mina and Vivek talking about the post-operative laxity, how you kind of counsel your patients, and if that kind of weighs into your consideration of a graft choice. And then maybe if you want to just touch base on one of the importances intraoperatively of kind of the orientation of your graft and those sorts of things that are also important to consider.
Okay, so In terms of the general, what patients should expect following the graft, if you have essentially a bone plug, it's generally you're expecting it to incorporate quicker. Generally, kind of what similar to like general principle within orthopedics, where bone heals more reliably to bone than tissue healing to bone. Where a fracture versus a avulsion, the bone is going to heal quicker and more reliably. That's probably the biggest advantage of the BTB autograft. Whereas you have to counsel your patients that a soft tissue graft is less likely to have the quick incorporation. It does require vascularization at the graft bone interface, and will take some time for the overall incorporation of the graft.
That kind of touches to Mina's point. Mina was asking about the reliability of the bone healing, so I think that helps explain that a little bit better.
In terms of all the surgeons I've worked with, you guys can obviously weigh in as well. I haven't seen a separate post-operative protocol depending on which graft was